Hi, I'm Rebecca Dennis. I'm a pediatric radiologist at the Children's Hospital of Philadelphia. Today we're going to be going over multimodality imaging of stomach and bowel masses in children. I have no disclosures. Abdominal complaints are common in the pediatric population, while masses of the gastrointestinal tract are rare in children, noting that benign masses are much more common than malignant. Primary pediatric malignancies represent less than 5% of all pediatric neoplasms. Multiple modalities are used for evaluation, usually when a child presents to their pediatrician or the emergency room with abdominal complaints. An x-ray is obtained, but that is very insensitive for evaluation of gastrointestinal masses. Much higher yield modalities, of course, include ultrasound, fluoro, CT, and MRI. Here's a list of multiple benign and malignant masses of the gastrointestinal tract, noting that this is not all-inclusive. The more common things that you're going to see are polyps, duplication cysts, maybe hemangiomas, neurofibromas, and then you get into the more concerning diagnoses such as lymphoma, GIST tumors, neuroendocrine tumors, and even adenocarcinoma. The first modality that we're going to talk about is ultrasound. Ultrasound is a great evaluation for the bowel. It involves no radiation, it's low cost, there's wide availability. Typically, patients don't require sedation. It's high resolution and real-time evaluation. Limitations, of course, is operator dependence, and bowel gas can limit the evaluation. What's also really great about ultrasound is that since it is real time, that you have the ability to troubleshoot and problem solve. For instance, if you're trying to look at the stomach, you can have the patient drink to distend the stomach if you're concerned about an intraluminal mass. At our institution, when we evaluate the bowel, we use both linear high frequency for higher detail and lower frequency transducers. Lower frequency transducers used to better visualize the deeper structures and overall assessment of, grossly thickened bowel wall and dilation and a deep mass. And the linear frequency is for more detailed evaluation. So here is a quick ultrasound. A 15-month-old male presents with bloody stool for 4 months. We see this echogenic lesion within the bowel, and we can see a nice stalk arising from the bowel wall, and there shows a central vascular flow, and this is compatible with a juvenile polyp. Next, we're going to cover fluoroscopy. Fluoroscopy is great because it's a dynamic exam and requires typically no sedation. There is radiation, although most institutions have a very low dose. Limitations with the exam is, of course, stool can obscure or mimic an intraluminal mass. Motion and patient cooperation is a big limitation within the pediatric population and can somewhat limit the examination. Also noting that it's just not as detailed, that you can see a filling defect, but it doesn't really tell the full extent of the bowel wall or the involvement of the adjacent structures. You can also see luminal narrowing, which can be from bowel wall thickening, but you don't know, is that from inflammation or is that from a large mass? Here's an example of a 10-year-old male with Banyan-Riley-Ruvalcaba syndrome, status post subtotal colectomy, and continues to have abdominal pain. With this syndrome, these patients have macrocephaly, skeletal abnormalities, and developmental delay, and most importantly, they have hamartomas, including intestinal polyps. So here's a single fluoroscopic image that demonstrates multiple intraluminal filling defects, which corresponds to polyps within the residual small bowel. So next is CT. CT is great because it's fast and typically requires no sedation, and there's also really good spatial resolution. Oral contrast is often required for intraluminal evaluation. Of course, there is radiation involved, but every institution should have pediatric protocols, which decreases the dose to the patient. Limitations with CT include a limited evaluation of the mucosa and submucosa. Also, wall thickening can be exaggerated or small masses could be missed due to underdistension. Also, timing of oral contrast can be difficult, and especially just having the patient drink the oral contrast can be limiting. Here is an example of a 13-year-old female with family history of familial polyposis syndrome and past medical history of juvenile colonic polyps, which were resected in 2009, presenting with hematemesis. She got a CT because she presented at the ED. Obviously, she has IV and oral contrast. We see these low-density lesions within the stomach. Here is a nice axial image showing the low-density lesions appearing to arise from the gastric wall. Due to this presentation, she ended up going for an EGD, which showed multiple polyps within the stomach, and they were biopsied, which demonstrated juvenile polyps. Due to the number of polyps, she was diagnosed with juvenile polyposis syndrome, and she is monitored every 6 months with EGDs. Unfortunately, 2 years after this exam, she was diagnosed with grade 1 adenocarcinoma, and she ended up having a gastrectomy, and she is currently in remission. Okay, lastly, we're going to go over MRI. So MRI is more sensitive and has great contrast resolution, and the biggest benefit is it involves no radiation. Big downside is that it can be expensive, and there can be limited availability. MRI does have quite a few limitations. The biggest one is patient motion, especially in the pediatric population. Other things that can limit the evaluation, especially for bowel masses, is bowel motion and just peristalsis in general. Also, underdistension can limit the evaluation. Something to kind of counteract that is you can use neutral contrast. Younger children also may require sedation, which would limit breath holding, especially with younger kids, and if they are sedated. Something to kind of counteract that would be some respiratory triggers. So we're going to go back to that fluoroscopic image that we showed of the 10-year-old male with the Banyan-Riley-Ruvalcaba syndrome, and they ended up getting an MRI. And so we can see multiple low-intensity lesions throughout the distended loop of a small bowel, corresponding to what we saw in fluoroscopic image, compatible with a bunch of polyps. We also were able to get pre and post contrast showing intense enhancement of the polyps. And this ended up being biopsied on scope, and they were multiple hamartomatous polyps compatible with juvenile polyps, and they were diagnosed with juvenile polyposis syndrome and is being followed. So next we're going to go over a few interesting cases, just showing different entities that have 2 or 3 modalities showing their different appearances. The first case is a 3-year-old male who presents with 1 week of intermittent abdominal pain with vomiting and diarrhea. Of course, the first line of imaging is an ultrasound, which shows a typical bowel-in-bowel appearance concerning for intussusception, except for this is within the left upper quadrant and has the appearance of colon. So here is another transverse image, and you see this lobular mass appearing within this intussusception concerning for an intraluminal gastrointestinal mass, and you can see central flow. Due to the concern for intussusception, this patient went for a fluoroscopic enema. At the time of the enema, the intussusception was already reduced, but we see this intraluminal filling defect within the transverse colon, which corresponds to what was seen on ultrasound. Due to wanting to get a better visualization and knowing the colon is now distended with contrast, a follow-up ultrasound was performed within the fluoroscopic suite, which demonstrated the known mass within the transverse colon, but then also we see an additional polypoid mass, which is better visualized because it is outlined by all the contrast that was already given. Here's a cine clip demonstrating just how it appeared in the fluoroscopic suite. We're seeing the contrast moving around. We see the polypoid lesion a lot better, and then we can also see the larger mass within the transverse colon. This patient ended up going for a scope, which demonstrated a large mass within the transverse colon, and it was biopsied, and it came back as a juvenile polyp. The patient also had 16 additional biopsies, and they all came back as juvenile polyps. Due to the number of lesions within the bowel, the patient was diagnosed with juvenile polyposis syndrome and is being followed closely. So juvenile polyps, they are the most common intestinal polypoid lesions in the pediatric population. More than 90% of all colon polyps in children are juvenile polyps. They're also referred to inflammatory or retention polyps. Juvenile refers to the histologic type of the polyp, not actually the age of onset. They are hamartomatous polyps, and they're limited to the colon. They can range from less than a centimeter in size up to 3 centimeters. They typically present 3 to 10 years of age and are uncommon before the age of 2 and very rare before the age of 1. No, they most commonly present with lower intestinal bleeding, and they're not associated with malignant transformation. Now, this is different from juvenile polyposis syndrome, which is autosomal dominant. 75% of parents will have the syndrome, where 25% of the children will have no family history. They are hematomas. They are multiple polyps throughout the GI tract. So where it differs is that these can occur in the stomach, in the small bowel as well. They can develop within the first few months of life, although most are diagnosed later in the first decade. They're different from the sporadic juvenile polyps, where to diagnose them with a syndrome, they have to have greater than 5 polyps in the colon, or they have multiple polyps throughout the GI tract, including the stomach or the small bowel, or they have any number of polyps but have a positive family history. So the really important thing here is that they have increased risk for carcinoma, and therefore management varies. Usually they will do yearly scopes, and they can do polypectomies if that provides symptomatic relief, but sometimes they can require segmental resections if there's cluster of polyps. Case 2, this is a 12-year-old male who presents with nausea and emesis. Supine and upright x-rays were performed, which demonstrates multiple air fluid levels concerning for small bowel obstruction. There's also this calcification within the right hemiabdomen. Due to the concern for small bowel obstruction, cross-sectional imaging was recommended and a CT was performed. So a CT was performed with IV contrast, which demonstrates obviously a small bowel obstruction as well as profound gastric mural thickening, in addition to multiple soft tissue lesions throughout the small bowel. There was presence of numerous and large lymph nodes, as well as this axial image demonstrating the calcification seen on X-ray, which appears to be within a lymph node. This patient also had a large centrally necrotic nasopharyngeal mass. This is the mass that was actually biopsied, and the patient was diagnosed with Burkitt lymphoma. So Burkitt lymphoma is a type of non-Hodgkin's lymphoma, and it's actually the least common type of lymphoma in all the age group, with incidence of 1%, but during childhood is the most frequent subtype of non-Hodgkin's with an incidence of 40%. It is the most rapidly growing tumor in kids. Doubling time is 24 to 48 hours. The age range can be anywhere from 0 to 20 years, but the median age is about 8 years old. So Burkitt lymphoma has been categorized by the World Health Organization into 3 types. There's endemic, sporadic, and immunodeficiency associated types. The endemic is more common in the head and the neck, and the sporadic is more common in the abdomen. The endemic variant is linked to Epstein-Barr virus and is observed particularly in Africa, where malaria is also endemic. The sporadic variant is the most common form in the rest of the world. So with the head and neck type, you're definitely always worried about airway compromise, but we're lucky that this type of lymphoma is very sensitive to chemotherapy. So clinical signs are usually due to compression, obstruction, infiltration of the adjacent structures. And the ileocecal region is the most common site affected, and that is typically just because it has the highest concentration of lymphatic tissue, and colonic and gastric involvement is quite rare. Gastric involvement usually shows diffuse infiltration of the gastric wall, like in our case. Intestinal involvement can show diffuse thickening of the bowel wall or more focal mass. It can trigger an intussusception and lead to a bowel obstruction, also like in our case. Mesenteric and retroperitoneal growth pattern is infiltrative, and you kind of get haziness of the fat. You can also have calcification, necrosis of the mesenteric retroperitoneal masses / lymph nodes, although that is very rare. So case 3, this is a 15-year-old female who presents with abdominal pain for 1 month and worse on the day of presentation. So, of course, first-line imaging is an ultrasound, and this ultrasound demonstrates kind of a bowel and bowel appearance concerning for an intussusception. It appears very vascular, and on the transverse view, the bowel looks super thick and just looks very irregular. The big thing that should kind of tip you off is that this is a 15-year-old, so 15-year-olds don't typically get an intussusception, and if they do, there's usually always a lead point. She also had hemoglobin of 5.2 with no history of bloody stools. So cross-sectional imaging was recommended before she was even considered to take to the fluoroscopy suite. So since she presented in the emergency department, a CT was performed. This is a coronal image demonstrating a large mass within the region of the cecum. It kind of has the appearance of the terminal ileum, and you're like, oh, this is thickening of the ileocecal valve. But here is another coronal image that shows that the terminal ileum is normal. So this is really just a large colonic mass. Here's an axial image that demonstrates basically kind of erosion of the colonic wall, and there's haziness of the fat. So this is highly concerning for malignancy. This ended up being biopsied, and she was diagnosed with colonic adenocarcinoma. So colonic adenocarcinoma is very rare in children, less than 1% of all neoplasms in the first 2 decades of life. The most common subtype is mucinous. And it's most commonly sporadic. It can be associated with syndromes like Gardner's, Cronkite Candida, Peutz-Jeghers. One thing with colon cancer is that they have similar imaging features as adults. It just is a regular mass-like thickening of the bowel wall, and you can have tumor infiltration of the colonic mesentery, and it can involve the adjacent vessels. One thing that's really important with kids is that the prognosis depends on time of diagnosis. Since it is rare, you can have a delayed diagnosis in children. Luckily, this kid, the lymph nodes were negative, but with the infiltration of the mesenteric fat, they were diagnosed with stage 3, but they had a right hemicolectomy, and they are currently in remission. Our final case is a 14-year-old female with past medical history of tuberous sclerosis presenting for renal angiomyolipoma follow-up. She got an ultrasound, and during the ultrasound noticed this heterogeneous mass within the right upper quadrant. It appeared adjacent to the tip of the liver and next to the right kidney, although it didn't definitively appear to be rising from either. The mass did demonstrate intense internal flow, therefore cross-sectional imaging, specifically an MRI, was recommended. The MRI demonstrated a heterogeneous T2 hypointense mass next to the liver and kidney, but did not appear to arise from them. There is adjacent bowel, but it doesn't appear to be causing bowel obstruction. There is restricted diffusion, and the dynamic contrast demonstrates heterogeneous enhancement of this mass. Due to this weird appearance, surgery decided to just go in and resect the lesion, and ended up being a colonic leiomyoma. So as we know, tuberous sclerosis is a rare autosomal dominant neurocutaneous syndrome characterized by benign congenital tumors, specifically renal angiolipomas, cortical subependymal tumors, and things like cardiac rhabdomyoma. So the most common gastrointestinal involvement are polyps, which are frequently multiple and can occur anywhere from the esophagus to the rectum. The prevalence is unknown but likely underestimated due to them usually being asymptomatic. So tuberous sclerosis can rarely involve things such as ulcers, fibrous tumors, adenocarcinomas, vascular malformations, and in this case, leiomyoma. So in conclusion, masses of the gastrointestinal tract are not common in children, benign lesions being way more common than primary malignant lesions, noting that those are very rare. Gastrointestinal lesions can have varying appearance depending on which modality is used, and using a multimodality approach can help troubleshoot these lesions. Here are my references, and thank you very much, everybody. I hope you have a great rest of your day.